Our outline is to talk about a few important issues pertinent to the pregnant inflammatory bowel disease patient or patients who may become pregnant in the future. So I want to talk about some preconception issues and patient counseling, and then talk about the medical management of IBD during pregnancy with an emphasis on the safety of the drugs that we use, and then just a brief mention about breastfeeding and vaccination of newborns as well. I'm going to skip over our case study for the interest of time because we are running behind. So let's start with this slide here. So this slide emphasizes the medication adherence during pregnancy, which can be quite low. This was a survey study that was done back in 2014 and 15 at the University of Toronto. And they surveyed 204 female IBD patients of childbearing age. So these are not pregnant patients, but females that are of childbearing age. And of those patients who were currently or had formerly been pregnant, almost half of them reported having stopped their IBD medications during pregnancy. And of those patients, about half of them did so without physician advice. So I think we have a responsibility to address this issue with all of our female patients who could potentially in the future become pregnant. So I think this is something that we should bring up at the first visit and potentially discuss at subsequent visits with these patients as well. So one thing I want to emphasize before I start talking about the safety of the drugs that we use, I want to emphasize there is a large body of evidence that tells us that active inflammatory bowel disease itself is associated with adverse pregnancy outcomes. So before we start talking about drugs, and we've heard a lot about shared decision making and balancing risk benefits, I always start by talking about how there is risk associated with active disease, as in the non-pregnant population, but is very true in the pregnant population as well. This is a meta-analysis published in Gut just over 10 years ago now that shows the risk of prematurity in patients with inflammatory bowel disease is elevated, and the same result we see in need for C-section. So clear. I'm not going to show you a lot of other data here, but suffice it to say there is a large body of evidence saying that active inflammatory bowel disease is associated with adverse outcomes. So this is another more recent meta-analysis that shows that birth outcomes of UC patients are negatively affected by active disease. So the column on the left there are the patients with ulcerative colitis without disease activity. In the middle is stable disease, and on the right is flaring disease. And I'll just point out the odds ratios are in the range of 2 to 3 for preterm birth, spontaneous preterm birth, premature rupture of membranes, and so forth in patients that have flaring but not stable disease. We get the similar results for patients with Crohn's disease here. So I think, again, an important point is to emphasize to patients that patients who may have trepidations or anxiety about using our medications during pregnancy, we need to point out to them that there is risk associated with active inflammation. And I'll show you that risk is probably greater than any risk from the majority of the medications that we use. So I tell patients that the goal prior to conception, so if we're talking about preconception counseling, the goal should be steroid-free remission for at least 3 months. So if we're in the situation where we have a flaring or active disease requiring corticosteroid use, we probably shouldn't be talking about trying to conceive until we get that disease under better control and in sustained remission. So there are lack of studies comparing or defining what is optimal disease management and so forth, and this is based largely on expert opinion. But another recommendation is that all patients should have objective disease activity assessment prior to conception. Okay, so part of that sustained remission, corticosteroid-free sustained remission, should be objective disease activity, not just symptomatic remission. So endoscopy or cross-sectional imaging are suggested when important management decisions are being made. And in my mind, conception, definitely qualifies. And so I do think about, and I counsel the majority of my patients that we should think about endoscopic or cross-sectional imaging evaluation of their disease prior to conception. All right, so let's talk a little bit about the drugs, medical management of IBD during pregnancy. So there are only a few drugs that we really consider as contraindicated, methotrexate and thalidomide. And then there are these 5-ASA drugs that contain dibutyl phthalate, which is at least in animal models, a teratogenic molecule. It should be noted that Asacol, the HD formulation of Asacol, prior to 2016 did contain dibutyl phthalate, but since the manufacturer has removed the dibutyl phthalate molecule from that product, so this is not as big of a concern as it was previously. So let's just talk a little bit about methotrexate. I think we're all probably familiar with the fact that this drug should be avoided in pregnancy. It is associated with a 23% miscarriage rate, a 3.4-fold increase in cardiovascular defects, a 2.6-fold increase in oral clefts. So the recommendation is that this drug should be stopped at a minimum 3 months prior to conception. If a patient does become pregnant inadvertently while taking methotrexate, the drug obviously should be stopped immediately. The patient should be taking a folic acid supplement if they weren't already, and this patient should be referred to high-risk obstetrics for evaluation. So oral and topical 5-ASAs in general, as I mentioned, without that dibutyl phthalate molecule, they are safe in pregnancy. Meta-analyses of 7 studies, which included over 2,000 patients, showed no significant risk of congenital abnormalities, stillbirth, prematurity, or spontaneous abortion. Okay, so what about thiopurines? This is a source of much anxiety in patients that I see in the clinic. They have a lot of concerns about taking what they view as a chemotherapy type drug or anti-neoplastic agent during pregnancy. So we have a large experience, however, with these drugs in pregnant patients. We have a meta-analysis of 9 studies that among IBD patients that showed no increased risk of congenital malformations in thiopurine exposed versus unexposed patients. We do have some conflicting data as to the association with preterm birth. However, if you look at the Swedish Health Registry, the risk of preterm birth in stable Crohn's disease patients is elevated with an odds ratio of 2.4, and the risk of preterm birth in active Crohn's is 4.9. And so we think, and what I tell patients again is that most of the risk to both the mother and the developing fetus is from active disease and likely not from the drug that we're using, and that does include thiopurines. So corticosteroids in humans, there are some conflicting data, but some possible association with cleft palate, theoretically higher concern for this during the first trimester. So we do try to avoid using it during the first trimester, although, again, the data are inconsistent, and in general, otherwise, corticosteroids are considered safe to use during pregnancy with the understanding that corticosteroids do carry the same risks in pregnant patients that they would in non-pregnant patients in terms of increased risk of infection and so forth. All right, what about anti-TNF drugs? These drugs are also generally considered safe. So adalimumab and infliximab are both IgG1 monoclonal antibodies, and therefore they do cross the placenta, particularly during the 3rd trimester. They are found in cord blood at 4 times the maternal concentration, and they can also be detected in the infant circulation up to 6 months postpartum. Certolizumab pegol, which is a pegylated FAB fragment, does not cross the placenta because it lacks the constant portion of the antibody that's required for placental transfer. Multiple meta-analyses show no increased risk of maternal or fetal unfavorable outcomes for any of these agents, actually. At least with certolizumab pegol, there is that theoretical benefit that there is the lack of placental transfer. And so some providers do choose to go with this agent in patients that are pregnant or may become pregnant. All right, so what about discontinuation of anti-TNFs during pregnancy? So this is a question that will come up, and the patients will definitely ask you about this. Say I'm stable on infliximab therapy. Should I continue this throughout the pregnancy? Should we make adjustments to the timing of our infusions and so forth? One common practice is to give, in order to minimize that placental transfer of the medication, which happens during the third trimester. One common practice is to try to administer the last dose of infliximab, or last infusion, at week 30 to 32, or for adalimumab, the last subcutaneous injection at week 34 to 36. And this is to, again, minimize exposure to the fetus. This is controversial. There's not a lot of data to support this. And then there are theoretical concerns regarding a drug hiatus, potentially triggering flare, or triggering formation of anti-drug antibodies or immunogenicity. We do have some data, and this is, I think, a more common practice in Europe, some data to support the discontinuation of infliximab during the second trimester, as early as week 20 to 22. So there are some practitioners that are incorporating this into their protocol for pregnant inflammatory bowel disease patients. There was a Danish trial that showed no maternal or fetal adverse events in patients that discontinued at week 20 to 22. Also, there is some work being done on looking at drug levels of anti-TNFs during pregnancy, and it seems that as patients progress throughout pregnancy, the serum concentrations of anti-TNFs do increase. And so there are some that advocate proactive therapeutic drug monitoring, especially during the second trimester, with adjustment of dose, with the idea to, again, minimize that exposure to the fetus during the third trimester and in the postpartum time. So I think, in my practice, this is something that has to be individualized. I do generally, as a protocol at our center, time my infliximab infusions to happen at week 30 to 32, and my adalimumab injections to stop at week 34 to 36, with resumption of these drugs shortly after, within days after delivery, assuming no complications. All right, what about the switch to monotherapy? So the question comes up in pregnant patients that are on combination therapy. Should one medication be discontinued? So data from the Piano registry show that combination therapy is really not associated with adverse outcomes. So this can be continued. Patients on, say, infliximab and thiopurine can continue both those medications safely throughout pregnancy. However, if there is a compelling reason, if the patient has a preference to stop one drug, it probably should be the immunomodulator and not the anti-TNF. We have 2 de-escalation trials that show that patients on combination therapy for over 6 months who stopped the immunomodulator, they did not have increased rates, at least short-term rates of relapse. All right, so what about the non-anti-TNF biologics? So for vedolizumab, the data in pregnancy are somewhat limited. One study that looked at all the pregnancies, including the studies in clinical development from 2007 to 2013, as well as the post-marketing studies up to 2015. This comprised 27 pregnancies. We had 11 live births, 5 elective terminations, 4 spontaneous abortions, and then 4 undocumented outcomes. 1 episode of corpus callosum agenesis, which in all honesty did not seem to really be associated with the drug. It was a single dose of the drug was given 79 days prior to conception. Otherwise, really no safety signals in this limited data. So the Otis data, from which encompasses experience from December of 2015 to March of 2018, that comprises 28 patients who are exposed to vedolizumab during pregnancy. And again, similar birth outcomes, comparing exposed patients to disease-matched controls and healthy controls. So basically, the takeaway point is vedolizumab, very limited experience during pregnancy, but that limited data that we have suggests that this is likely safe. In contrast, the other approved biologics there is very limited data for ustekinumab and tofacitinib. So the data in pregnancy are extremely limited at this point. The few kind of case series that we have show no true safety concerns, but again, due to this limited experience, we have to really carefully consider the risk-benefit ratio. And these should not be our drug of choice in pregnant patients, and we should consider discontinuing these drugs during pregnancy unless there's a compelling reason to continue them. All right, so what about breastfeeding and vaccination of newborns? Another question that will come up often when seeing these patients. So methotrexate, again, probably safe to say if methotrexate in pregnancy comes up anywhere, including on an exam, the answer is no. So this should be avoided during breastfeeding. Other medications, however, should really not influence the decision to breastfeed, including 5-ASA agents, steroids, immunomodulators, and biologics. Infants of mothers treated with anti-TNF, and this is important to communicate to the patient and to the obstetrician and pediatricians. Infants of mothers treated with anti-TNF should not receive live virus vaccines during the first 6 months of life. So in the U.S., this means the oral rotavirus vaccine. All right. So take-home points. Number one, controlling disease activity is generally more important than potential side effects of medications. So I really do pound this into my pregnant or young female patients. Deep remission at time of conception is the goal, so both symptomatic remission as well as documentation of biochemical and ideally mucosal healing. The only absolutely contraindicated medications in inflammatory bowel disease are methotrexate and thalidomide. Thiopurines are probably safe, and we probably should not be stopping them if the patient is stable. And anti-TNFs, steroids, and 5-ASA products during pregnancy are safe. Again, the data on the newer biologics, tofacitinib and ustekinumab, are at this point limited. All right, and I'll close with this slide. I just wanted you all to be aware that the AGA has come out with a new clinical care pathway for the treatment of inflammatory bowel disease patients in pregnancy. So this is kind of hot off the presses. It emphasizes many of the points that I included in the presentation here, so I recommend you all check this out. Also go to the CCF website, and lots of good educational information and tools for pregnant patients. And I'll stop with that.